Today we'll discuss a case of a critically ill septic patient to illustrate the thought processes that ought to be used in selecting appropriate empiric antimicrobial therapy in such a patient. This patient was a 56-year-old, previously healthy man who was admitted to the hospital with severe diverticulitis. Empiric antibiotic therapy was initiated at that time with ampicillin plus sulbactam. However, the patient continued to do poorly and required a partial colectomy. The ampicillin sulbactam was continued, but on the third postoperative day, he developed confusion, fever, leukocytosis, tachycardia, and hypotension. Blood pressure was 90/60, pulse 130, the respiratory rate was 20 per minute, and his central venous pressure was only 6 millimeters of mercury. On examination, there was no evidence of infection of the surgical wound and no other evidence source of possible infection. The central venous access site appeared to be non-infected. It was noted that a bladder catheter was in place. Initial laboratory studies found that the patient had a total white blood count of 14,900, and his serum lactic acid level was elevated at 3.9 millimolar. Fluids were rapidly administered, and his blood pressure and central venous pressure both improved. Chest X-ray was rapidly obtained and showed no evident intrapulmonary disease. Serum creatinine was normal, and his urine output was adequate. Blood and urine cultures were rapidly obtained. Because of concern that the central venous catheter might have been the source of infection, the catheter was removed and replaced at another site. A CT of the abdomen and pelvis was planned, and antibiotic therapy was rapidly initiated. First question is, what antibiotics should be used in this circumstance? And the types of considerations that one might take include the potential sites of infection. In this patient, the most likely sites are possibly the central venous catheter that had been in place for 3 days, his urinary tract, and not unlikely an intra-abdominal infection related to the surgery. We must consider the likely pathogens, and those, of course, would differ by these individual sites. With central venous catheter infection, although a broad range of organisms are possible, gram-positives, including gram-positives resistant to beta-lactams, must be considered. The urine is culture, if positive, would likely yield a gram-negative aerobic organism, and if the site of infection is the abdomen and related to a leak from the surgical site, the organisms present would reflect that of the fecal stream and be a mixed flora involving both aerobic and anaerobic organisms, gram-negatives, and possibly gram-positives. What is the likelihood of antibiotic resistance in such a patient? This infection was hospital-acquired, and it occurred while he was receiving ampicillin and sulbactam. At a minimum, one must assume that the infecting pathogen or pathogens are resistant to that beta-lactamase inhibitor combination. One needs to take into account the local antibiogram. Are there multi-drug resistant organisms that are being transmitted within the unit and other such institution? And finally, what is your margin for error? What I mean by this is, how critically ill is the patient? What is the likely outcome if the antibiotic regimen you choose is inadequate? And we know that in many infections of this sort, that initially administered antibiotics that don't cover the pathogens causing the infection are associated with greater mortality. So our coverage given what our likely sources are, should include staphylococci, including especially coagulase-negative staphylococci because of the possibility of central venous catheter infection, enterococci because of the abdomen, and we would, given the fact that this infection occurred in a patient receiving ampicillin-sulbactam, we would assume that it was ampicillin resistant. Anaerobes are almost certainly present if the intra-abdominal site is the source, but of course the antibiotic regimen the patient was receiving provides good anti-anaerobic coverage. And then finally, aerobic gram-negative rods, including multi-drug resistant organisms in some circumstances, must be considered. We also must consider the possibility in such a patient that Candida may be playing a role. Candida could be part of the flora present in the intra-abdominal site, but perhaps more importantly, in a critical circumstance, is the possibility of a central line infection due to Candida. The antibiotics chosen included vancomycin, which of course would cover the coagulase-negative staphylococci that are oxacillin resistant, and would also cover ampicillin-resistant enterococci, unless, of course, they were also resistant to vancomycin. And if this were in a circumstance where vancomycin-resistant enterococci were high on the probability list, as for instance, as is commonly seen in liver transplant patients, either linezolid or daptomycin might be preferable. Gram-negative coverage with piperacillin-tazobactam, which also provides, of course, anaerobic coverage, as does a carbapenem. Either of those would be adequate and appropriate, likely appropriate coverage for the gram-negative pathogens as well as the anaerobic pathogens. Now, if we decide on those antibiotics, then we have to decide on things such as dosing. We know from studies with vancomycin vis-a-vis Staph aureus bacteremia that there is an appropriate pharmacodynamic target which involves hitting in a ratio of the area under the curve of exposure to the drug to the minimal inhibitory concentration of the organism of at least 400. We also know from studies with Staph aureus that in the patient with normal renal function, you actually often can't reach that level if the MIC is 2 or, of course, greater. However, once again, those studies were done with patients with, those studies refer to patients with Staph aureus, mostly MRSA, bacteremia. We also know that if we want to achieve a high enough blood level and reach the pharmacodynamic target, as reflected in serum trough vancomycin concentrations, that giving a loading dose improves the likelihood of achieving that trough at an early point in time. So the current recommendation is to get in a critically ill patient when vancomycin is used, that to give a loading dose in the range of 25 to 30 milligrams per kilogram, and then to follow this up with weight-based dosing, which in the patient with normal renal function is generally in the range of 15 milligrams per kilogram every 12 hours, and to follow the dosing and to alter it based on therapeutic drug monitoring, which involves trying to achieve a serum trough concentration in a critically ill patient of 15 to 20 micrograms per mil. Again, much of this is derived from treatment of Staph aureus bacteremia, but until one knows the isolate is an appropriate approach to the patient. What about dosing with piperacillin-tazobactam, which is what's chosen in this particular patient? Being a beta-lactam, the pharmacodynamic target involves achieving a serum concentration that's maintained above the minimal inhibitory concentration for at least approximately 50% of the dosing interval, particularly if one requires bactericidal activity. This number varies in terms of whether you want bacteriostatic or bactericidal activity, and is variously reported, but this is the general range. Achieving this, especially if the organism turns out to have a relatively high MIC to piperacillin, albeit considered susceptible, this is best achieved by either giving continuous infusion of the antibiotic or by prolonging each individual infusion. And this has been discussed previously by Emily Mlee, in which she demonstrated the better achievement of pharmacodynamic targeting with infusions lasting 4 hours as opposed to 30 minutes. Another element of managing this patient is to get the antibiotic into the patient as rapidly as possible. Current recommendation is to have a target of trying to get the first dose in within 1 hour of the recognition of severe sepsis. So in this patient, vancomycin was administered an initial dose of 2,000 milligrams over 2 hours, followed by 1,200 milligrams every 12 hours, consistent with his body weight and his normal serum creatinine. Piperacillin tazobactam was administered in a dose of 4.5 grams every 8 hours, but with each dose administered over 4 hours. It was elected in this patient to not give empiric coverage for Candida infection. 2 days later, the patient was clinically stable and in fact was afebrile and had normal vital signs. CT of the abdomen and pelvis, which had been performed, did not reveal an abscess. Urine and blood cultures, however, grew Escherichia coli, which, as one would suspect, was resistant to ampicillin sulbactam, but was susceptible to piperacillin tazobactam, meropenem, and cefazolin, among other antibiotics. At this point, as the information became available, it was possible to perform a so-called antibiotic timeout to step back and look at the available clinical and laboratory, including microbiological information, and to optimize antibiotic therapy at that point. In some cases, you can improve on the therapy by giving more potent agents or broadening the spectrum based on the microbiological data. In others, you may be allowed to refine the treatment by de-escalation, for instance. You would of course, resolve any bug-drug mismatch. De-escalation might involve eliminating antibiotic coverage redundancies, narrowing the spectrum of therapy, optimizing the dosing if that has not yet been done, or even in some cases, although not likely in this particular patient this early, a switch from IV to oral administration of an antibiotic. And at that point, one should also begin planning the likely duration of antibiotic therapy based on knowledge of the infection, which in this case turned out to be a bladder catheter-related episode of urosepsis due to E. coli.